All right, so let's dive in. I'm Jason Engel. I'm a urologist. We usually call our database of old patients here, and so probably a lot of you might know me or might know a doctor that's worked here at my practice, Urologic Surgeons of Washington. For those that don't know, I'm trying to do a webinar series that's always growing, so I very much invite you to go to my website, which is dcurology.net. And there's also a YouTube channel out there, but all of these are in the educational video tab of my website. It's a very highly trafficked site, and I think a lot of people around the whole region watch these videos. So today we're going to dive into a topic I've been meaning to do for a while, and it's a relatively simple topic, and it's not a very controversial topic. So some of my other talks are the world according to me. This is a little bit of that, but this is much more straightforward information. So we put it as everything you need to know. This is not everything about stones. I'm not going to be able to, in probably the 30 minutes I'll talk, and then we'll have questions. I'm not going to tell you everything about stones, but I think it's everything you need to know. And then one last housekeeping item. For those of you who have been to other talks of mine, you'll know that sometimes it's an industry-sponsored talk, and in that circumstance, I have to split the talk from the actual question and answer. I actually think the best part of it are the questions and the answers. If you have one, please put it in the chat box. It's only I see it. It's anonymous. Not much to be embarrassed about with stones, but I'm going to bank them up. I have my illustrious person that created my website, CJ Peters, helping me here. His company is named Fortress. So if you ever need a website and you like mine, go to that too. But let's get started. So kidney stones 101. And so I guess the number one question is a simple one. What's a kidney stone? Obviously, what it is it's a stone that forms in the kidney. So we're not talking about bladder stones. That's a different discussion. We talk about that with enlarged prostate. So what's a kidney stone? Well, our urine is basically a chemical solution, and it has minerals, and it has wastes, and it has, not everything in urine is bad, but if you're as old as me or older, before we had internet and we were constantly on our phones, we would maybe do projects to entertain ourselves. I like to explain kidney stone formation much as how you might make something called rock candy. If you're old enough to remember that, that's just a concentrated sugar solution where the minerals want to come out of solution. You give it something to crystallize on, and you get a piece of rock candy. Kidney stones are the same thing. It's just different minerals. Some people form them and some don't, but once it starts, it kind of keeps building upon itself, just like the stick you put in for rock candy. Here's pictures of actual kidney stones that are broken up here, and you can see they have different appearances based on their compositions, and we'll talk about that. Kidney stones it's a very common problem, and it's particularly common in areas where people get dehydrated because they're sweating. And so certainly DC accounts for that. I was just in Miami, and I can certify it is definitely hot and humid there. So the entire southeast region is really called the Stone Belt. That's where the incidence is much higher, largely just because we tend to be less hydrated in those areas. So congratulations, if you're in DC, you're in the Stone Belt. The most common time you'll be dealing with a kidney stone is between ages 40 and 60, but the first average age of when you might start first dealing with one might be 35. And if someone gets a stone, and we'll talk about what that means, half of those people will get another one in their lifetime. So it's not 100%. It's not a guarantee, but it's at least a 50% chance you'll deal with it again. And just like people that get nosebleeds, there's people that form stones and there's people that don't. And so there's people that are totally dehydrated and they're never going to form stones. And there's people that are just unlucky and they form stones. We'll talk about the propensity to do that, but it has mostly to do with body chemistry. And if I'm throwing out factoids about stones, probably the number one thing, if any of you ever come in with a stone, maybe it was just found on an x-ray you got for something else, maybe it's because you were in pain and you went to an emergency room. The discussion I give you is very much going to hinge upon how big the stone is. Size definitely matters with stones. And so generally stones less than 5 millimeters, we're going to try to let you pass that. And stones greater than 5, we might still try to let you pass that, but your odds are not nearly as good. In general, we say that if you have a 5 millimeter stone, the odds of it getting from your kidney all the way down to your bladder and out is 50-50. And then there's a different discussion if you have really big stones. And so We can talk about what that is. Really big stones are stones that would never pass. They're never even going to leave the kidney. And the question is, what do you do about those and what trouble would they cause in the future? So size matters. 5 millimeter is an important set point. Now, I'm just going to throw these things out there just because there's a few factoids that are interesting. These are not the only stone compositions. These are the most common stones. And here's the bottom line. If anyone just says, I had a run-of-the-mill kidney stone, they had a stone comprised of these two minerals, calcium and something called oxalate. Oxalate is largely from your dietary intake. Calcium is from your body metabolism and your calcium intake. And it can come in two different forms. And monohydrate is much more dense than dihydrate. So that's something that I might want to know about if I was offering you a treatment. There's other stones called uric acid stones, and those are stones that tend to be softer, rounder. And why they're so important, you can't see them on plain x-ray. You'll see them on a CAT scan, but you won't see them on a plain x-ray. That's how we know it's a uric acid stone. And although we still go after uric acid stones because they can still block you and cause trouble, we have the option of changing your urine pH. Uric acid is acidic and it crystallizes in an acidic environment. So if we make it an alkaline urine, we can melt those. So that's the important factoid to know about uric acid stones. There's something called struvite stones. Those are a certain chemical composition we don't need to go into here. But struvite stones generally form in the setting of chronic infection. And the problem is that the matrices of that chemical stone is going to trap bacteria within it. So if one has what we call an infection stone or a struvite stone, we're really going to try to get rid of all the stone, because until you get rid of all the stone, you will never get rid of infection. There's certain organisms that tend to create the atmosphere and the environment and the chemicals that would produce stones, and one of them is called Proteus. So if I keep seeing someone that keeps showing up with a Proteus bacteria UTI, I'm thinking, I wonder if you have an infection stone. But the most common things like E. coli do that too. So that's an interesting thing we deal with. And then something that's actually quite rare, but it's something worth noting in a urologist's office, is if you have cystine stones. These are by far the hardest. They're going to be very hard to break up with standard techniques and lasers and things like that. So, those are very rare. I rarely see that, but that's just, if I'm going to list the most common and the most interesting, this is what I'll list. This is just a function of saying that there are other ones. There's things called phosphate stones. Urine phosphates are actually quite normal. And all the stones have different sizes. So if someone ever was to ask me or look at one of my operative notes, I'll say what they look like. This looks like a calcium oxalate stone. They tend to be your standard. They look like a mine, like in a harbor. And you see these are round uric acid stones. Different shapes can kind of give me a sense of what they are. So they have different shapes because crystalline structure of different chemicals create different crystals, and that's why they have different shapes. So something to point out there. So this is where I'm going to talk about symptoms of a kidney stone. So the number one thing to understand is that, well, first of all, I'd like to say in terms of symptoms, it's almost as common for someone to say, I have a kidney stone because I have back pain, or I'm assuming my back pain is from a kidney stone. I can tell you that patients that have had kidney stones in the past, where they've passed them and they've had the drama of dealing with that, they tend to, every time they have back pain, they assume they have a stone. It's usually not a stone. But the number one symptom of having a kidney stone, meaning a stone in your kidney, is you don't have any pain. Stones in the kidney cause no pain. So if someone goes to the emergency room, they say, I have back pain, and they did a CAT scan on me. And the problem is kidney stones. It's very common that they may have a stone in their kidney, but that's not the source of their pain. So pain from a kidney stone is not from the jagged edges of the stone. And sometimes they're quite jagged. You would say, oh my God, that's going to tear me up. Pain from a kidney stone is purely from obstruction. So if we're looking on this drawing, and it's not a perfect drawing, the kidney makes urine and it dumps it into these channels, I call them bedrooms, they're called calyces, and the stones form in those calyces, and they're usually much bigger than this picture shows. but then they drop out like pieces of an iceberg falling into the water. And it's only when they drop into the main compartment of the kidney, that's called the renal pelvis, I call it the living room, is when they're then going to want to engage the pipe that goes down to the bladder. And that's called the ureter. So in this schematic, you can see there's a stone and it's backed up like a dam is backing things up behind here. It's this backup would create pressure. The pressure would cause pain. That backup is called hydronephrosis. So if you can have a stone, you can even pass a stone and have no pain as long as it never obstructed you. It can be small enough to go in this pipe. The pipe moves just like a snake that's eating a rat or an egg, and it pushes things through just like the intestine. But pain is from obstruction, and it tends to be, and we can usually tell where your stone is based on where the pain is. In this schematic, since this stone is stuck up high, it's only blocking the kidney. And this person is going to say, I'm having pain in my flank. And important to understand, people with bad backs have low back pain. And that's not where your kidneys are. Everyone thinks your kidneys are down here. But if your kidneys were below your ribs, we certainly would never be able to play football and lacrosse and all these things. Your kidneys are behind your ribs. So if it's not behind your ribs, it's not your kidney. But if it's first starting and it's blocked up high, it's going to be pain in your back. So if someone says, I'm having pain here, I already know the stone's high up. And then if it makes it down, and we're going to talk about this a little bit as to where stones get stuck, it can say, well, now I'm having pain here and here. And you usually are pointing right where your stone is. And if it gets low enough near your bladder, you're going to say it's burning when I urinate, or there's pain at the tip of my penis, or, all stones can cause blood in the urine. And very important to understand that only stones that are in the pipe here tend to cause blood in the urine, not sitting up in the calyx. And sometimes it can cause foul-smelling urine, but mostly if that's infected, it can be cloudy from the crystals from the stone. But stones, and I get the question so many times, why did you go into urology? And it's a long story, but one of the answers is there's very few emergencies in urology. But one of the emergencies in urology is when there's a stone blocking your urine, and then that urine behind the stone that's not flowing gets infected. That's an emergency. That person can start saying, I'm having fevers, I'm having chills, I'm fatigued. So pain is one thing. Fevers will always say you need to go to an emergency room. We'll talk about that. Lastly, if a man says, I'm having pain that rotates to my testicle, that the stone's about to pass. The stone is very low. It's right near the bladder. I always say it's like the baby's head crowning. It's about to pass into the bladder. And the last thing to say is, every man ubiquitously thinks that the pain is going to be horrible when it comes out of their penis. The diameter of the urethra, which is the urine tube in your penis, is way bigger than the stone. If it makes it to your bladder, believe me, if it made it through this tube, which is about 5 millimeters in men, it's about 4 millimeters in women. If it makes it into your bladder, it's just going to come out after that, with rare exceptions. So it is not going to hurt your penis. Notice here it doesn't say penis pain, but that's always what patients are worried about. We've already talked about, you can kind of know where the stone is by where the person's describing it. And I sort of described already 3 places: up high, about here, and down by your bladder. Those that are old enough to have played board games might know the game Chutes and Ladders, where your man goes, and if it lands on a certain spot, it slides down the ladder to the next place. Well, if the stone gets past each of these toll gates, it gets usually to the next toll gate. And those 3 places are this area here. This is called the UPJ, the ureter renal pelvic junction. And it's like a coin sorter, and they get tighter as they go. So stones that might be 10 millimeters get stuck here. Then the next place, the Chutes and Ladders, if it makes it past here, it's not on this diagram, it's going to make it where that tube, which is called the ureter, drapes over the blood vessels to your leg. So there's a little bit of a kink there. So it's a little tight spot. And we call that a stone at the vessels. Every urologist knows what a stone at the vessels is. And that's going to be right about here. And then finally, it's going to be down where the ureter meets the bladder. That's called the ureter vesicle. Vesicle means bladder junction. And so when a patient's about to pass the stone, they usually say, there's something weird going on with my urination. I feel like I have to urinate a lot. this is weird. I'll go to the toilet, but nothing comes out. That's a stone that's irritating your bladder. That's a good sign. It's about to pass. And we talked about the concept of pain is from obstruction. Hydronephrosis is the phrase for backup of urine or obstruction. So if we don't see hydronephrosis on a scan, we know that you're probably not having pain. And it's a different discussion. Our most common discussion is going to be someone with a stone in the ureter because they're the ones that had pain. But sometimes they can also have pain. If a stone is big enough in this renal pelvis, it can block the kidney. It's not going to cause trouble in the kidney itself. Kidney stones in the kidney just sit there and don't cause obstruction. You can see there's no backup behind here. Sometimes there's a special outpouching of the urinary tract called a calyceal diverticulum that doesn't drain well. Those can get stones in them, and those cause trouble. So where the stone is often dictates what we tell you to do, what treatment there is. So that's, you know, size matters, location of stone matters, how much it obstructs you matters. And then this is, I think, an important point. When is a kidney stone an emergency? In other words, when should a person go to the hospital? Well, if a kidney stone has not been diagnosed, then there's fear involved. People are wondering what's going on, what's wrong with me. And in that circumstance, they'll go when they get diagnosed. But if someone already knows they have a kidney stone, people will say, what should I be on the lookout? Well, as I already said, if you have a fever and you have a stone, that means you go to an emergency room because that kidney has to be drained somehow. If there's infection under high pressure, the bacteria in the urine can easily go backwards into the bloodstream. The kidney is the filter of all the blood. So that person can get septic. So that's one of the rare emergencies in urology. The other reasons is if the pain just won't go away or it's intractable. I can't find a spot to sit comfortably. There's nothing I can do. I can't work. I just can't do this. Well, that person obviously needs better pain control. But it's important to understand that when patients go to the emergency room, they're thinking, I'm going to get a procedure now. It's going to be convenient. Not really in my practice. The next day, they usually feel fine. And even when they go home, usually the pain gets much better, almost always. And that's because the kidney's smart. You have two kidneys, and if one of them senses pressure, it'll be under pressure at first, but then the kidney will shut itself down and stop making urine and let the other one do the trick. And that's why people will always say, I passed my stone. And I'll say, how do you know you passed your stone? Well, my pain went away. That doesn't mean anything to a urologist. We always say, you know, lack of pain doesn't equal lack of stone. So usually if someone shows up with a stone, we're going to look for some kind of closure. And that is either that the person screened their urine, had it in their hand and said, I passed it, here it is, or that we repeat a scan to prove that it's gone. If that's not done, and there's always the chance that the stone will stay lodged there, and eventually the kidney eventually after autoregulation will stop working, and people will show up with a dead kidney down the line. So it's always going to be, our job is to show that there's closure of a kidney stone event. Sometimes when in any area of your body, if you have a hollow structure that is under pressure, you tend to get nauseous. So people with kidney stones that are obstructing them will get nauseous at first and might even vomit. And if that won't stop, of course, that's something you have to get an IV for in the hospital. And, you know, everyone always wants to know, of course, you know, why did I form a kidney stone? And, you know, usually it's just bad luck. The number one thing is you don't drink enough water. None of us do. I don't either. Dehydration, you know, the more concentrated your urine, the more concentrated the minerals are, the more they'll want to crystallize out, just like rock candy. A very sexy thing to talk about is, well, there's certain foods that are going to cause stones more. They might change the pH of your urine with protein. They might have more oxalate. This is generally like, you know, nuts and green leafy vegetables and tea. And so there are some times where you'll say, well, here's somebody that drinks 4 pots of tea a day. Maybe they're doing this to themselves. There are certain medical conditions where the glands that regulate calcium, they're called the hypoparathyroid glands, are making too much of that hormone and then releasing too much calcium. So your kidneys are just doing the right thing, which is getting rid of it. There's circumstances where you absorb too much chemicals from your intestine, and usually it's you're absorbing too much oxalate. So that's called absorptive hypercalciuria, or too much calcium in your urine. And then sometimes your kidneys just don't do a good job of holding on to it, so they put too much in there. And we can figure this out by the test that I'm going to tell you that we get if we do a big workup. Some medicines might cause you to be prone. For a while, there was an HIV medicine called Crixivan that would form stones. One thing to understand, things like Tums and calcium supplements, they don't tend to form stones, believe it or not. It's complicated. We explained how urinary tract infections can cause struvite stones, and commonly people will say, I have a family history. And this comes up a fair amount, diagnosis to say, how can I prevent them? If any of you ever see me with a stone, I'll always say, you've had a stone and you have a chance of having it in the future. And 90% of stone prevention is drinking more water. And so you could just drink more water and see how it goes in life. Or we could do a lot of tests, and those blood tests are listed here. It's the combination of all of these are going to tell us, are you absorbing too much chemicals? Are you leaking too much out of your kidney? Is there something wrong with your parathyroids? And we figure it out by putting those variables together. But I usually ask patients, do you want to do all those things? You have to collect your urine for 24 hours. It's a little bit of a hassle, i.e., if it's going to say you need to drink more water, and it might recommend taking a medicine for the rest of your life, that's usually a twice-a-day medicine. Most patients say, I'm not willing to do that. And I usually, in my practice, say that the free advice is drink more water, but that's always an option. And sometimes there are circumstances where you really got to not have a stone. If you only have one kidney, it's always an emergency. So that's something we would want to work on. If you've had a lot of operations, you might say it's worth taking medicines for, but I don't give it automatically with the first stone. Patients always think they need to give me the stone. And that's actually, notice that's not on here. That's oftentimes the least helpful of all of these things to determine how we can help you. So those are some important things. And as I said, people, we'll talk about this under prevention, but the dietary thing always comes up because it's what people read on the internet, but very hard, way harder to do a low stone diet than a loose weight diet. So those are general pearls, general ideas, and this is what you'd hear if you had a stone. And so let's dive in a bit to treatments. And here, this is a relatively simple affair. Some of my other talks are, way more complicated. The subject of prostate cancer is very complicated. What do I do? How do I get treated? And this is a little simpler, okay? So the first thing to determine about treatment is, do you need to be treated? Again, if someone comes into my office, and certainly if they have kidney stones in their 3 millimeters, 2 millimeters, they may say, oh my God, I need that treated. But that's just, in my opinion, not correct. That they will pass on their own. Patients will know what they are. They don't have to be scared to go to an ER. So the best option, okay, with kidney stones that are small, 4 millimeters or less, is to give them time to pass. And that doesn't mean you won't have some discomfort, but it's always better to pass it on your own. And so I commonly will say, why don't we wait a month or so and see if it goes away? And we can do something more emergently if we have to. Usually someone's personal schedule dictates what we do. I'm going on a trip. I want this settled. I don't want to have this problem on my great trip to Alaska or Antarctica or a cruise. So that's usually part of the stone speech I'm giving, is what's your schedule like. But these are the most common, these are the 4 most common procedures, and we'll just zip through them. The first is called ESWL. That's extracorporeal, meaning outside the body, shock wave, ultrasound, sound waves, lithotripsy. So lithotripsy means breakup stone. There was a while, and I supported this as well, where machines were created. I mean, I could give you a history lesson of lithotripsy. The original ones were in certain locations. I trained at Northwestern. University of Virginia was the regional one here, where it was a gurney where you actually were moved like a side of beef after being put asleep, and we would put a stent in you and roll and move you on a pulley system across the ceiling and drop you down into a tub of water as a way to transmit the sound waves. And those actually worked the best, but that was an enormous affair. You have to understand that up until that point, everybody that had a kidney stone used to have a big incision, open stone surgery to go after them. So urologists were always in the operating room cutting people open, and that's very rare. So that was extremely revolutionary in the 80s and 90s, the development of these machines that could do that. They got smaller, they got easier. I'll show you a picture of one. There's no more water bath anymore. And we tried doing that for stones that are in the ureter. And that was a good idea in the beginning when we didn't have good scopes, but it's rare to do them in the ureter now. It's mostly for stones sitting in the kidney, asymptomatic patients. And it works. It works about 80 to 85% of the time. It's not a fantastic success rate, but most people choose it because it's the least invasive. The higher success rate, and I don't know if I could say the most common way to go after kidney stones, definitely the way to go after a stone stuck in the pipe is called ureteroscopy. So that's a scope going up the pipe. When I was a resident, that was still a pretty big scope. It was a big deal to do that. Now we have very small scopes. It's a very routine matter for us to go after stones now this way because of the technology. Urologists were the first to bring a lot of technologies to medicine, but actually the first to bring lasers to medicine to break up stones. There are some urologists that go after kidney stones this way too. There's nothing wrong with that. I usually give the patients the choice. A lot of patients, unfortunately, get on the internet and they get very worried and nervous about a stent, which is a plastic tube that keeps the ureter open. There have been some trials and some attempts to do these procedures without stenting. It doesn't go well. Patients wind up in the ER, so we tend to place the stent. So this may have a 94% success rate, but I notice usually patients choose the lithotripsy, even though it's a lesser success rate, because they want to avoid the invasive nature of the ureteroscopy, but it's an excellent procedure. And then the bottom two are ones that I think if you specialize in stones, this is something you'll do more, maybe because you see bigger stones. These are what you would do for really, really big stones. Percutaneous nephrolithotomy, again, was the next step of what do we do when you have a really big stone in the kidney. These days, the technology of ureteroscopy is such that generally I can do huge stones maybe in 2 settings with a very minimally invasive procedure versus a much more aggressive percutaneous nephrolithotomy. What does that mean? It means putting a tube directly into your kidney and then doing more of an operation where we make that a big hole and look in with a scope and go that way with a much bigger scope to go after stones. There are some people that are very, very skilled at that, but I very rarely have to resort to that. I offer that to patients, but they generally are going to choose the less invasive option of ureteroscopy. But very occasionally, you need the nephrolithotomy if you really have a big branch stone that goes in a lot of directions, like one of those struvite stones. Those are called staghorn stones, by the way. You can get a stone that completely fills the inside of the kidney, and it looks like a stag, which is a male deer with the antlers. That's why they call it a staghorn stone. That would be one where you're really going to have to do something more aggressive. And there are certain occasions where you have a very big stone that's in that renal pelvis, where people like me that do a lot of robotic surgery would find it to be the most simplest to just find that renal pelvis and open it and remove stones that way. So we'll just dive through just a couple pictures. This is all on my website, dcurology.net. So these are just, I have a page on everything I do really on that site, and we're expanding it all the time. This is what a standard machine looks like. Here's a patient, their kidney would be here. This is their flank. And this is a big gel pad. And there's going to be, it's kind of almost like a shock, a spark plug in here that goes boom, boom. And that sound gets transmitted through this gel instead of water. And then it's, in a high technology way, it focuses on the stone. So that's lithotripsy. And really that's it. I'm not really touching a person. As an experienced tech, we put the stone in the crosshairs and we cross our fingers. These are pictures from my site for ureteroscopy. So here is, doing a scope, and there'd be a stone stuck in the pipe. I'd look up with a scope to get to it. It might look something like this. This is what a laser fiber looks like. That green thing is called an aiming beam. This green thing is always called a safety wire. We pass a wire up to the kidney, so if something bad happens, we have something that bridges things. You can see I've drilled holes in this stone here. And eventually it's a bunch of little pieces, and if they're small enough, we just let them pass, and if they're bigger, this wire contraption is called a stone basket, where we'll grab them and pull them out, such that this patient had this stone to start, and they look like this at the end. You can see where the stone used to be. this is a very not atraumatic situation. Sometimes it doesn't look quite so good here. This is why we have to place a stent to keep everything open. The stent has holes on either side, so the urine will enter and then bypass areas of obstruction. So we leave it in there to keep a person from having obstruction. Remember, obstruction equals pain. So stents are a good thing, not a bad thing. And well over 90% of procedures are going to be those two things these days. The days of open stone surgery would have been really good for me, surgeons like me, because I like doing surgery, but we can do almost everything with a combination of these first two procedures. And then the others, which are percutaneous nephrolithotomy and robotic surgery, and this is from my site too, it's more surgery. So these are going to be more in the operating room. A percutaneous nephrolithotomy is not always a big deal, but it does have a significant risk of injury and bleeding. And you have to stay in the hospital typically. And then sometimes there's robotic surgery too to do this. So this is a younger me, and this is my surgical assistant I've operated with for 21 years. I'm very loyal to Eric Struther. So this is just to give you a sense that these are in the operating room. I don't have pictures of it. They'd be more gory, but these are rare in my practice. Every now and then it calls for it. Once I'm done helping somebody with a stone, the usual scenario is that they always want to know how to prevent things. The number one thing is just drink more water. I need to do that as a habit. We all need to do it as a habit. If we were to send off your urine and ask for an analysis, they would say, well, they need to drink enough water to make 2 liters of urine a day. None of us makes that. It's an enormous thing. But you can imagine if you have very dilute urine, stones don't come out very much. You can do some dietary changes. The better shape you're in, sometimes people would argue the less stones you have, but that's if you stay hydrated. There's some wives' tales associated with what to eat, what not to eat. One of the biggest things about stones is to get them out of there. Otherwise, they just keep crystallizing. And then sometimes if we do all those tests, it will indicate certain drugs. This is an old antihypertensive, which as a side effect decreases how much calcium comes out in your urine. Uracid K is really citric acid. It would be like eating 100 oranges in a day, lots of grapefruit in a day. That does 2 things. It alkalinizes your urine, which tends to inhibit stone formation. And citric acid in itself is an inhibitor of stone formation. And uric acid, by the way, also causes a condition called gout. A lot of people with gout take a drug called allopurinol. But mostly we don't do that as much anymore. We will use Uracid K to melt those stones. And as I said, the dietary changes are difficult to do. And those are the main points. I tried to kind of keep this as close to 30 minutes as I could, and it looks like I'm there. And now I very much invite, we do have a fair amount of people here, and I'm going to start answering questions, and you put them in the chat box. I'll see them. And I'm just going to start answering them as I see them. And I'll just keep answering them until they're gone. And maybe we'll have fewer with this lecture than others, but we'll see. But please fire away whatever you're wondering or thinking. No one's going to see it, but other people that listen to this on the web will probably benefit from your questions. So fire away if you want to. One question says, "What if I only have 1 kidney?" Well, how would I handle that? That's a completely different discussion when I see a person with 1 kidney and a stone. Because there's 2 different things to think of there. The first thing to think of is first of all, I tend to be relatively leery about doing procedures if you have 1 kidney, because I want to do everything I can to avoid the rare complications that might occur with those things. And one of those is a scar in your ureter. That's a bad problem if that happens. So every time I look up with a scope, it's rare, but there's a chance of having a scar. On the flip side, if you do have a stone and you start to pass it, the problem is you can't have that auto-regulation because you don't have the other one to pick it up. So it tends to be a real shared decision-making process. But generally, we tend to be a little more aggressive when we see stones, larger stones, because we don't want you to be blocked and have what's called renal failure. Okay, so anyway, that's stones. That's what if you have one kidney. So it's complicated. How do I know I'm passing a stone? Well, one of the number one things is to see blood in your urine. So that's a big point of presentation. I saw blood in my urine. People worry, oh my God, I have cancer, but it'll be much more common to find that you're passing a stone. Remember, stones that are passing cause blood in the urine. And sometimes, we all have aches and pains. I know I do. So you're not really sure what is that. It's not that bad. I don't know. But the classic scenario is the pain that I talked about, which will start in the back and kind of migrate down. The opposite is also true. How do you know I've already passed my stone? You usually don't, so you have to be sure and get another x-ray. And it says, do you ever actively look for stones if there are no symptoms? Well, I'm gonna change that question a little bit. Do we ever screen people that are just walking down the street? No, I would say there's way bigger fish to fry than that. But the bigger time that comes up is I'm finished dealing with the patient with stones. Maybe I've even gotten them stone free, okay? But then the question is, what's the follow-up? I didn't have a slide there. And that really varies from doctor to doctor. It just has to do with their own personal philosophy. Mine tends to be much more pragmatic, as to say, why don't we just deal with the stones when you have them? Certainly I had a partner that was here, Dr. Losi, and he used to get an x-ray every year on everybody. I don't necessarily see the point of that to look for trouble, but that's offered to a patient. So I tend to be more of a don't ask, don't tell, and we'll figure out if you have stones later on. But I leave that in the patient's hands. And what's the largest stone I've ever seen? That's a good question. I actually have, I have a little collection in the corner here. It's kind of gross because I wanted to take a picture and put it on my website. I've seen stones certainly that filled the entire kidney. So in terms of those numbers we talked about, maybe, I saw a woman the other day that I know it's at least 5 centimeters, and she didn't treat it before. And I don't know if she's going to treat it now, and it'll be more, complicated to treat it now. But so the stone, as I said, can fill the entire kidney, and it can be huge. But most of the time, it's a big stone is going to be 15 millimeters, something like that. That's a big one, but certainly I've seen bigger. The next question, do I always try that extracorporeal shockwave lithotripsy before laser lithotripsy? No, absolutely not. If it's a stone in the ureter, I'm most commonly going to do ureteroscopy. If it's a stone up in the kidney, I'm going to say, hey, that has everything to do with size and where is it. So that's what that was about. There are patients with a very large stone where I'll say, look, we're going to have to probably do 2 procedures, maybe even 3. Now we could do that percutaneous operation if you want, but generally when I compare and contrast them, I still find that patients would rather do 3 little things that are outpatient than 1 bigger thing. Of course, that's up to the patient. It's very doctor dependent. I used to do lots of percutaneous procedures. It's just that the technology has got to where ureteroscopy tends to be the way to go. And so sometimes we will say, hey, what I'm going to do first is I'm going to look up with a scope, and I'm going to see your stone, and I'm going to chip away with the laser, and I'm going to see how easy and how much I can get out that way, because then I'll get a sense of how hard it is. And if I get a sense it's a real soft stone and I've gotten rid of half of it, I might say, now let's do a lithotripsy and see if that'll break up, because I know how soft it is. We call that sandwich therapy. And I might even look up a third time. This is for huge stones, 3-4 centimeters. If you don't want a percutaneous approach, that woman I talked about that didn't agree to the percutaneous approach, she might agree when I see her next week to the lesser procedures. But no, I do not always try ESWL before laser lithotripsy. That's usually the patient's decision. And the next one is, what about drinking lemons in your drinking water in a regular basis? Does that help prevent kidney stones? That's a great question. So if you want to know what's the best thing you could do, free advice, I don't have to give you any medicines. It would be to drink, real lemon juice or lemonade, because remember that urocit K is just citric acid. So if you're saying, I'm going to drink lots of water, that's 90% of it. And on top of that, I'm going to add another couple percent of success by putting real lemon. And, you can't put drink mix in there now because there's not much real in there. But if you were willing to have real lemonade that was strong, then it would make a difference. If it's just barely lemon flavored, it probably wouldn't. But that's probably the best thing you can do is to say, I'm going to be in the habit of drinking water with lemon juice in it. That's the best thing you can do, other than taking pills all the time. The next one is, if I have 2 stones in the right kidney that are 5 millimeter and so maybe 2 5 millimeter stones on the right and 2. Well, one side has 5 millimeter and one side has 6 millimeters, but that person has no symptoms. Okay, so that's maybe they have stones on both sides. It says, should I drink more water and wait, or should I do something now? And this person has another complicated situation called a horseshoe kidney, which is just where the 2 kidneys aren't all the way over here. They're a little bit kissing in the middle. And this person's passed stones in the past, and I guess I helped this person in 2018. The question is what to do. And there's no, if that person is just, they're sitting there, they're not causing dilation, they're not causing any harm. That's going to be the age-old question. There's nothing wrong with taking a wait and see, and we'll deal with it when you have to, which is when it drops down into the ureter. In some ways, that's easy for me. It's really just a question of how proactive you want to be, and I think that just has to do with, do you travel? Are there circumstances where if you had pain, it would be a big deal to get that taken care of? And that's just a lifestyle question. But this person asking this question is not harming themselves if they decided to take a wait and see approach. It's not going to be something in that circumstance. They're not enormous stones, 5 6 millimeters. They've passed them before. If you've passed previous stones, you tend to be able to pass bigger stones because the ureter stays a little dilated. So that would be totally a judgment call and completely reasonable, especially in a more complicated scenario, to say, why don't I just leave those alone and I'll deal with them when I have to. Patients, that would be a shared decision-making one, but that would not be something where I said there's a right answer. Nothing wrong with waiting if you decided to do that. Next one says, how long after pain onset to having kidney failure? Well, first of all, we're given 2 of a lot of things so that we don't have failure. If we were to check your kidney function with 1 kidney, it's almost the same as with 2. 1, you're designed to lose a kidney. You're designed to lose a testicle, an ovary, an eye, and this is the whole point. We only have 1 liver, but if we remove half of it, it regenerates because we only have 1. So I would like to say, instead of how long after pain onset to renal failure, it's how long can a kidney stay obstructed without getting damaged? I'd say about 4 weeks. It depends how obstructed it is, of course. 4 to 6 weeks. So you're commonly, I saw a patient today, I said, why don't we give you a month? But if the stone is still there in a month, I'm generally then going to say, man, maybe we should do something about this and get this over with. So there's a month is kind of the sweet spot to say you have nothing to lose by waiting. And I'm generally going to encourage people to wait if they're stoned, if they have at least a good shot at passing it on their own and they're not miserable. This person's asking now, what food should you limit consumption of? Tea, collard greens, peanuts. Notice I had said this person's giving a good list of what you're going to find on the internet, okay, which is they're going to say, leafy greens is high in oxalate. Well, try eating a diet that doesn't have a lot of leafy greens. I mean, I hope you're eating a diet with leafy greens. You'd have to say, well, let's see. I have a little less stone risk, but of course, then I'm not really healthy because I'm not eating any green vegetables and leafy greens. So I always say to patients, like I said, if you're drinking tons of water and you're having some, drinking lemons all the time and doing that, to me, that's something you can do. That's something that's not that big a deal to make part of your life. But to say, I'm not going to eat nuts and I'm not going to have tea and I might not have coffee and I can't have chocolate and it is such a hard diet to adhere to. I say, go for it. Whatever's on that list, if you feel like giving it up, that's fine. But I find that to be a relatively inconsequential part of stone prevention. So it's good if you can do it. There's like an unending list of things not to eat. But I think hydration and citric acid consumption are things that you can roll into your life. Okay, so the biggest thing is if I see a young man, these days it's very common for young people in college, et cetera, to always have a pot of tea. It's kind of a trendy thing. And so I've seen people where I said, listen, you're telling me you're having 4 pots of tea. A lot of tea, real tea, oftentimes has more caffeine than coffee. So, hey, that's a lot of tea, but I might say, hey, maybe the tea is something you're going to have to get away from. But of course, if he's drinking that much, he's probably addicted to the caffeine. So again, hydrate, hydrate, hydrate. That's what I'd say. Next question is, if I've had several stone in my 30s, but not for 30 years, and this person hydrates a lot, is it likely they won't get others at this point? Well, when that person says I had several stones in my 30s, now again, that person's probably saying I passed several, because you wouldn't know you have them unless you got a CAT scan. So if that person may say, hey, I've kept them away by hydrating. And the only way to answer that question would be to raise the periscope, get a CAT scan. I skipped over this as to, how do we look for stones? And these days, it should be noted here that, they have something, a CAT scan is how we look for stones. But there's this CAT scan now called a low dose CT, a low dose CAT scan, which is very, very low radiation. And so we get those at the drop of a hat. They're relatively cheap. So I think there's a good chance if that person's making a big point to hydrate that they may not have any other stones, but they may not know, and they maybe have some in their kidneys at this time. Next question is, what happens to the stent after ureteroscopy? We remove it, so it's temporary. There are people that leave a string, a fishing line coming out of it. I find that to be very awkward. It tends to get pulled, so it's halfway in and out. It's done so that the patient doesn't have to go through the anxiety of what's called cystoscopy in the office, but I pride myself. I'm pretty good at talking people through that. It's not a big deal. So I don't usually leave the string, but it's a 1-minute procedure of looking in with a scope into the bladder, seeing the stent, and just gently sliding it out. So sometimes it stays longer. The typical person in my practice might get a procedure Wednesday or Thursday, and then they come back for a quick visit on Tuesday to have the stent removed. They're wide awake. It takes no time in the office. And so that's what that is. This person says, oh, the other question they wanted to clarify, because I was stumbling over how many stones do they have. This person has 2 5-millimeter stones maybe on the right, and 2 6-millimeters on the left. My answer would be the same. Those are not massive. If they're massive, I usually say, look, if they're massive, they're growing. They grew to be massive. If you don't do anything, we're only going to have a bigger problem later dealing with it. Those are not in the category of a very big problem. Those are still very amenable to the easy things we do that we talked about, lithotripsy and ureteroscopy. So same answer there to that person asking the question. This person's going back to the one kidney thing. Do you do shockwave treatment if you only have one kidney? I would probably preferentially do shockwave treatment if you only have one kidney, again, because this is an opinion. My own opinion is I don't want to touch your ureter. I don't want to mess you up, and I don't mess anything up. It's very low risk. I mean, nothing is no risk, but it's very low risk to do a lithotripsy. Very low risk. So normally with one kidney, and if it's not a huge stone, I will do a lithotripsy, maybe even at a lower threshold than I would have otherwise. And with the idea that if it gets stuck and it doesn't, doesn't pass, then I could always do ureteroscopy if I have to. So that's expanding on the one kidney thing. I'm going to try to understand the next question. I'm going to start zipping through a little quicker here so we don't stay too long, but I love the questions. Thank you so much. I was getting nervous at the beginning. So it says, if you need to see a patient 2 or 3 times, maybe for 5-millimeter stones, over what time period would those visits be? I'm not sure I understand that question, but that one I'm going to pass because I'm not sure what that means. So, if you're saying if I've had 3 different stone procedures for 5-millimeter stones, what would the visits be? Ask that question again, and I'll try to answer it for you at the very end. And if I don't get to your question, by the way, I'm so easy to reach if we do a telemedicine or virtual visit, et cetera. So here's another one. Hello from Canada. Is lemon juice concentrate good to add to the water? Yep. More you can pucker, the better. The more it is, the better the citrate. If you're drinking something that tastes really good in terms of lemonade, there's not enough lemon juice in there to really help you with stone formation. This says several years ago there was a stone and it was removed. They're saying from their urethra, maybe it was the ureter, and they gave them a low purine diet. That's kind of a low That's mostly a low protein diet. And do I recommend this diet? Again, I've kind of given my idea of diets. There's nothing wrong with those diets, etc. I tend to be a real pragmatist. If that's something that is easy for you to adhere to, that plus hydration is a good idea. But for me, it's the hydration is the most important thing than the dietary changes. There's another person saying, I have a bunch of small stones in the kidney, and the largest one is 5 millimeters. Should I wait and see? Wait and see would be fine. Having a lithotripsy for the 5 millimeter one, so you don't have to deal with it later, would be fine too. So it's always one or the other, totally up to the patient there. And now here's someone that says, I've had 5 or 6 major kidney stone episodes, which usually means pain, ureter stone, over the last 30 years. And is there anything extra this person should do beyond just waiting for the next time and drinking lots of water? So this might be the person in my practice that does get the 24-hour urine collection. Let's pretend that person's needed 5 or 6 procedures. You don't want to do that forever. So once that's going to be one of those stone formers we talked about. And if that's going to be a situation of, hey, if that person says this is bad enough that I'm willing to take medicine, then I'm willing to do the tests. And that person might be to that place. But, some of the stones pass on their own, etc. So even that person might not want to do it. This is a great question. Does limiting salt intake help? Yes, it does do that. Okay. I can't answer the exact maximum salt per day because it's just something where lowering that does help. It has to do with the exchange. Sodium is a positive ion, and calcium is a positive ion. So limiting sodium has to do with how your body handles calcium, and it is a good idea. It's a complex mechanism, but that is another recommendation that's usually done, a low salt diet. In fact, that was called, I can't remember, the DASH diet. And so actually the #1 dietary recommendation doesn't tend to be limiting nuts and tea, etc. It has to do a lot with what's called the DASH diet, which is actually a cardiac diet, a low salt diet. So you could look that up, the DASH diet. That's why they call that one stuff Mrs. Dash. If you remember that, it's a salt substitute. It's part of the DASH diet. It's low salt. Does ultrasound see stones? Ultrasound does see stones, but it's notorious for kind of mistaking the size of stones. So when someone sees me with an ultrasound and it says I have a 5 millimeter stone or a 10 millimeter stone, I'm always going to get a low dose CT because that's the gospel. The CT is the gospel, not the ultrasound. And also ultrasound won't tend to show ureteral stones. It shows the kidney or the bladder. It won't show in between. I call that the dark side of the moon. It can show if it's blocking your kidney, but there's no substitute for a low dose CT. So, an ultrasound is good. Low dose CT is better. And here's a good question I get a lot. Is there a correlation between kidney stones and gallstones? And the answer is no. Completely different mechanisms. That patient is just unlucky twice. And last question, and this is good timing. So am I saying that if it's a small stone with one kidney, that I would not wait to let it pass and I might proceed to treatment? Well, that's a judgment call. Again, it's choices. I mean, it's different when someone has cancer, et cetera. I can be way more opinionated with this. I think if I'm helping a patient, I'm going to say these are the options. If it's a small stone, I might say, well, you may want to be proactive so we don't have to deal with this later, or it's an emergency. Stone in a solitary kidney is more commonly an emergency. I think if it was a 3 millimeter stone, I would definitely not fool with that. If it's a 4 millimeter stone, I'd probably still say, look, let's just see if you can pass it. I don't want to mess with you. If it's 5 millimeters or higher, I oftentimes say we ought to think about being proactive, but it's your choice. I think I'd put it that way. If it was a 10 millimeter stone, I'd say, look, we need to do something here. You're going to make me do something more aggressive that I don't want to do. So hopefully that kind of gives you a sense. The answer to that question has everything to do with size in terms of where I'm going to push you, but it's never an absolute. If it's more of a 10 millimeter stone, I'm going to say it's not logical to leave that there. You're asking for trouble. So that's pretty good. I think those are great questions. This is all going to be on my website, dcurology.net. This has really been very successful. I'm glad I did it. I'll be adding things to this. There's some upcoming webinars. There always are. Some on the same topics. There'll be new ones that I do on my own. So thanks so much for sticking it out. Almost everyone that signed up for this talk stuck it out to the end. That's very rare. And you came up with enough questions to make it worthwhile. So thanks much. Please do, easy to see me anytime. And thank you for joining me. I'll see you guys next time, or anytime. Okay. See you all later. I'm going to sign off.